Hi everyone, good evening. Welcome to the second episode of Dr. Tristan Anaesthesia Tutorials. I'm just having a little chuckle to myself here. I started to record this video once and then I noticed that my ironing board was in the background, and then I tried to remove that, started again, and my box of unopened things and stuff I have to pack away was in the background. So third time lucky, here we are. First things first, guys, thank you so much. I really can't thank you enough. The response has been overwhelming, positive. The number of views, subscribers, the number of TikToks, everything. It's really awesome. It's a bit overwhelming, but I'm excited. We will be on Apple Podcasts properly tonight. It took me a little bit of time to figure that one out. But obviously we're on YouTube, we're on Spotify, we're on X, we're on Instagram, we're on Reels, all of it. And if there's anybody who is Chinese or who is in China somehow watching this, thank you. And we will hopefully, before we go live on the 1st of August with subscriptions, be on, I think it's called Himalaya in China. So watch this space for those in China and Hong Kong, Japan, etc. So I'm very excited about that. So guys, for episode 2 today in our pediatric anesthesia tutorials series is a topic that I just couldn't resist doing. I know that I said I think we were going to do neonates, but I was having a bit of interactions with a colleague of mine and had an interesting child that I did an MRI on. And I was looking in my peds folder and I came across this topic and I just absolutely had to do it. So guys, what we're going to be talking on today is one of my absolute favorite topics. It's something that I've got a lot of experience in. And it is, I love the title of this talk. I gave it Help. I've been allocated to Peds Cath Lab. So for me, a normal Thursday, every Thursday at Barra, and sometimes every Tuesday as well. So this was one of my absolute favorite regular lists that I did with the fabulous cardiology team at Barra. Dr. Vijay Mammon and Prof. Kutsia and Dave Klook, just to mention a few. But we had honestly an amazing team, and I really used to enjoy that list, and we used to do it every Thursday, and it's one of the few lists that I miss, and I really am excited to give this talk. And Professor Saliers, excuse me, not Kutsia, I knew I was saying the wrong name, I'm so sorry. So Prof. Saliers, but really, they were a great team and I loved working with them. And I'm hopefully going to be starting a list with Dr. Dave Klook, who is a phenomenal peds cardiologist, pediatric intensivist. And he is going to be our first Ask the Expert on pediatric cardiacs. And we're going to go through a few case scenarios with him. And what I sort of envisioned was a bit of a roundtable discussion with some trainees, myself and Dave, and we'll present some clinical scenarios and see how they would have managed them. So guys, without further ado, let's get going. Help, I've been allocated to Peds Cath Lab. So this is going to be the outline of our talk. Okay, guys, so this is going to be our outline. So I'm going to go over congenital heart disease, and I'm going to go through the approach to the pediatric congenital heart, and we're going to talk about obviously acyanotic, cyanotic, but we're going to divide it into a different way that I think is a much more useful way. I like to describe these in terms of what's happening to pulmonary blood flow. Is it increased, decreased, or the same? We're going to talk about cath lab. What you need in cath lab. I'm then going to go through the approach to the child with congenital heart disease. I'm then going to tell you my rules, which are by no means exhaustive, and remember, not totally infallible, but they served me really well in Peds Cath Lab. When it goes wrong, I'll tell you what to do. and how to identify what the problem is. And then we'll talk about a few special cases. So I really hope that this will be an exciting talk for you guys. I'm super excited to be doing it today. All right, so what do you need to know? I think you really need to, firstly, as a baseline, understand congenital heart disease, okay? So in your mind's eye, as you sleep, as you go to the toilet or whatever, I want you to be thinking of what is the fetal circulation, what is the neonatal circulation, versus what is the adult circulation, and those are different things. You need to develop an approach to congenital heart disease. You need to understand which cases are, by no means routine, but regular, that we do often, versus those that we don't do and it presents a unique challenge. Develop your own anesthetic techniques. This is something where you really, need to find your own recipes in your own experience, and what works for you, and you will find things quite easily. And then you need to be able to manage complications in the cath lab, and this is really where we earn the big bucks. There is when it goes wrong, we need to be able to understand what is happening with our shunt, what is happening with the heart, and the pressures in the 4 chambers versus the SVR and the PVR, and it can become quite a challenging thing, but I find it very exciting. So guys, at the beginning of this talk, I'm going to give you 4 scenarios, make a little mental note or a physical note. And they are: a 14-day-old neonate presents after birth with sudden onset cardiac failure and cyanosis for a diagnostic cath plus minus intervention if the lesion is amenable. We've then got a 2-year-old child with a tetralogy of Fallot for diagnostic cath to plan their surgery. We've then got a 3-year-old child who's got a VSD that on echo is amenable to device closure. And then we've got a really nice one, a 4-year-old child with a hypoplastic left heart for diagnostic cath. So make a note of those guys, keep them in mind, and that's what we're going to be discussing in this episode. So the first thing I said is you need to understand the fetal heart, and you need to understand the newborn heart or neonatal heart. So remember, guys, that in utero, okay, you have a placenta that is hugely vasodilated, a very low vascular resistance bed. And so your systemic vascular resistance in a fetus is very, very low. Now, they're not breathing, so the lungs are not necessarily needing blood supply. They're all collapsed, their alveoli, so their pulmonary vascular resistance is incredibly high. And as such, they have a physiological normal right to left shunt. How is that achieved? It's achieved in 3 shunts that are visible in a fetus. The first one is the foramen ovale, the connection between the atrium and the on the right and the atrium on the left. Now this stays open until birth, and what happens then is that when the child takes its first breath and PVR drops, the pressure in the right atrium drops, and when the placenta is removed and the umbilical cord is cut, the fetus's left ventricle, or now the neonate's left ventricle, has to pump blood against a high SVR. So the left atrial pressure increases and the foramen ovale flap is pushed closed. And we all know that if that doesn't happen, we call it a persistent or patent foramen ovale. We then have the ductus arteriosus, which is the next normal shunt. And again, we get a shunt from the pulmonary artery with a high pressure into the aorta in a fetus that has a low pressure. And again, once the neonate is born, the pressure in the pulmonary artery drops below the pressure in the aorta, and the shunt reverses. And again, with the increase in oxygen tension that occurs when a neonate takes its first breath, there is a contraction of the ductus arteriosus. Remember, this is inhibited by non-steroidals, so this should be, this is hastened premature closure of the ductus by non-steroidals, okay? So this should not be given in any neonate 28 weeks and above pregnancy. Fetus, excuse me, is the word. I'm a little bit tired today, guys. And then the third shunt that is not here is the ductus venosus, and that is in the liver, so that the liver is bypassed as well. That gets closed when the umbilical cord is clamped. So there's three physiological shunts that happen in the fetus. It's the foramen ovale, shunts right to left atrium. It's the ductus arteriosus, shunts pulmonary artery to aorta. And then it is the ductus venosus, which bypasses the liver. So when the baby is born, the umbilical cord is clamped. The PVR decreases because the lungs expand with the first breath. The SVR shoots up sky high because we now have an actual afterload that the left ventricle has to work against. That reverses all of these shunts. And then when the cord is clamped, the venosus obviously is no longer getting flow. So the foramen ovale closes. It should be fully closed within 14 days. And the ductus closes due to contraction of the muscular layer there, normally within 28 days. Now, the problem with the ductus in particular is it requires a little bit of intimal muscle in that duct to actually contract to close it. And that is lacking in premature infants below 32 weeks of age. So a lot of them will tend to have a PDA, a patent ductus arteriosus. Sometimes it closes on its own if we give them prostaglandins. Sometimes it doesn't, and then it could be, most of the time, it's closed with a device these days. But sometimes if the anatomy is not amenable, we will close it with an open procedure. So that's the normal differences between the hearts. So this is the classic definition of congenital heart disease that we've always had. We've got acyanotic and cyanotic. However, if you look at the next one, this is what's really important, because by knowing what is happening with pulmonary blood flow, you will be able to manage the lesions and understand the lesions better. And I'm going to spend a bit of time on this. So acyanotic lesions, remember, these mean that these lesions are left to right shunts, or there's no shunt at all. But there is no increase in deoxygenated blood being shunted into the systemic circulation. So when you have acyanotic lesions, obviously you cannot have an acyanotic lesion with a decreased pulmonary blood flow, because otherwise the child would be cyanotic. So therefore, acyanotic lesions can only be an increase in pulmonary blood flow or due to an obstruction to blood flow. So we know that an increase in pulmonary blood flow is an atrial septal defect, a ventricular septal defect, a patent ductus arteriosus, or an AV, atrioventricular canal. Obstruction to blood flow from ventricles, the most common is the coarctation of the aorta, aortic stenosis, and then congenital pulmonic stenosis. Now, cyanotic lesions, these can again only have decreased pulmonary blood flow or mixed pulmonary blood flow. If you had an increase in pulmonary blood flow, you by definition cannot be cyanotic generally. So what are the lesions that are cyanotic, that have got a decreased pulmonary blood flow? Well, by far the most important lesion that you need to understand in the cyanotics is tetralogy of Fallot. And then the next one is tricuspid atresia. And then those with mixed blood flows are essentially those where you have systemic blood and pulmonary blood going in the wrong directions. And this happens most importantly in a transposition of the great arteries or the great vessels, where the aorta comes off the right ventricle and the pulmonary artery comes off the left. Total anomalous pulmonary venous return or drainage is a unique, very rare condition whereby you get venous drainage from the lungs venous drainage from the systemic circulation going into the systemic side of the heart, into the the left atrium. Truncus arteriosus, that is a common outlet between the pulmonary artery and the aorta, and that is because of the failure of septation during embryonal development. And then lastly, hypoplastic left heart syndrome. So let's go through these concepts again so you understand why this is important. So in an unborn neonate, in a fetus, we look at the ratio of pulmonary blood flow to systemic blood flow, okay? And we apply that principle to all of these congenital cardiac lesions, okay? So in a fetus, as I've said to you, you've got almost no blood going to the heart, okay? Well, excuse me. You have almost no blood going to the lungs because of this very high PVR, because of these very constricted lungs, okay? So all the blood is shunted from the right to the left. So in a normal fetus, we could say, for a numbers game, the pulmonary blood flow to systemic blood flow ratio is 1 to 10. So for every 1 ml of blood that goes to the lungs, 10 ml of blood goes to the systemic circulation. Now that's great, okay? That's perfect for the fetus, and that's how we evolved so that the fetus could survive. Now we know, though, that when the fetus is born, the heart now goes from a parallel circuit to a series circuit. And we know that in a series circuit, the output of the right ventricle has to be the same as the output of the left ventricle. So therefore, pulmonary blood flow to systemic blood flow ratio in a normal neonate is 1 to 1. In a normal child, it's 1 to 1. In a normal adult, it's 1 to 1. So for every 75 mils of stroke volume from the right ventricle that goes into the lungs, 75 mils of stroke volume from the left ventricle will go into the aorta. It has to be that way. It's always that way in a normal heart. Okay. So now we need to consider the consequences of a change in this ratio. What does that mean? That means that we need to consider the fact that if we have an increase in pulmonary blood flow, that is going to lead to some very specific, very easily defined consequences. And I'm sure if you guys think it out, right now you're shouting them out. You're saying, okay, well, an increased pulmonary blood flow is not good because we've got these very weak, very low resistance, low muscle mass pulmonary arteries and vessels. They are not used to a very high pumping, thrusting flow. If you imagine a VSD, okay, the most common acyanotic lesion that we correct in the Cath lab, you have got the right ventricle and the pulmonary artery on the right side being exposed through a hole between the ventricles to left ventricular pressure. So you have a right ventricle that in a normal term infant will have a systolic pressure of no more than 20 millimeters of mercury, now being exposed to systolic pressures of 80 to 100 from the left ventricle. So that immediately causes right ventricular hypertrophy and pulmonary hypertension, and can eventually catastrophically lead to cor pulmonale, and that is right ventricular failure due to pulmonary hypertension, and the most catastrophic congenital cardiac lesion, Eisenmenger syndrome, where the right ventricle is so hypertrophied that and the PVR is so high that the blood now shunts from the right ventricle back into the left atrium, and you get a VSD being converted from a cyanotic to an acyanotic to a cyanotic lesion. So that's the first consequence, RVH, pulmonary hypertension, and eventual cor pulmonale. Secondly, this increase in pulmonary blood flow predisposes them to edema, pulmonary edema, as well as increase in infections. And they don't have blood going to the rest of their body, so they don't grow very well. They become stunted. If you have a lesion with a decrease in pulmonary blood flow, what that means is that the pulmonary blood flow to systemic blood flow ratio is now 1 to 5. Okay, whereas in the previous scenario, it was 5 to 1. What that means is that you now have a massive increase in systemic blood flow. So they get peripheral edema, organ congestion, hypertension, possibly. And by having a decrease in pulmonary blood flow, they are cyanotic. The cyanosis itself, remember, causes hypoxic pulmonary vasoconstriction, which increases PVR, which worsens the shunt, which leads to RVH and cor pulmonale. So that's why I think it's so important for you to understand whether there's increased or decreased pulmonary blood flow. So if we look at these most common types of congenital heart disease, first picture, we have an atrial septal defect. As we said, a simple hole, the foramen ovale, hasn't closed. Or in embryonal development, the entire septum hasn't closed and you could have something called a common atrium. Now that will cause a moderate right to left shunt. So therefore a moderate increase in systemic blood flow relative to pulmonary blood flow. So therefore this is an acyanotic lesion. Why is this the most forgiving lesion, and why are up to 10% of adults walking around with a small ASD or a probe patent for Raman ovale? Well, because the pressure in the left atrium is only about 10 to 14 millimeters of mercury. So the shunt across is, I don't know where to stop. Okay, guys, so if we look here at the first picture, this is an atrial septal defect. And this is the most moderate and or mild, should I say, of the left to right shunts. So this is an acyanotic congenital heart disease where the pulmonary blood flow is increased and the systemic blood flow is decreased. So there is a patent for Raman ovale, or the septum hasn't developed properly, and blood will shunt from the left atrium to the right atrium. However, this lesion is very forgiving because the pressure in the left atrium is not that high compared to the pressure in the right atrium, because both of the atria are meant to be low pressure chambers. And so therefore, the shunt fraction is quite small, maybe only less than generally 10% of stroke volume. So often these go asymptomatic until later in life, or they're an incidental finding. However, if they are big enough to cause symptoms and to cause a noticeable decrease in systemic blood flow, causing stunting and poor growth, etc., and lots of respiratory tract infections, then we will most of the time take them to Cath lab and put in a device to close it. The next congenital heart disease on this side is the one that I said is the most often coming to Cath lab, and this is a ventricular septal defect, or a VSD. You can get, especially in trisomy 21, an AVSD, so where there's a connection between all four chambers, okay? But here, you've got a very high pressure, muscular, powerful left ventricle, shunting a large portion, often more than 50% of the stroke volume with each beat into the lungs. So these are picked up early because they get infections, they're not growing, they don't want to feed. Again, a lot of them are able to have device closures, but some require open surgery. Then down at the bottom, we have another acyanotic congenital heart, but this one is the one with obstruction to blood flow, and that is coarctation of the aorta. This is a congenital narrowing of the aorta that occurs most commonly distal to the third offshoot of the first branches, and this causes an incredibly high SVR, okay? So they are hypotensive post the lesion because there's such a low blood flow, and they are hypertensive in the upper limbs and in the brain before the lesion. This can also most often be fixed with a device, okay? However, some of them will again require it to be opened and clipped. And then on the bottom right here, we have the most common cyanotic congenital lesion, and this is the tetralogy of Fallot. Now, what is the tetralogy of Fallot? Okay, the tetralogy of Fallot is four things, as we said. So it's a VSD, okay? But this is a VSD with a right to left shunt. Why? Because they have infundibular stenosis, okay, pulmonary hypertension, and a right to left shunt. So I'll go through again, all right? So they have a VSD, they have a right to left shunt, they have right ventricular hypertrophy, and they have right ventricular outflow obstruction. Most commonly, infundibular stenosis, sometimes pulmonic stenosis. So I'll say those four again for a tetralogy of Fallot. The most common cyanotic congenital heart that you'll see. Number one, you have a VSD. Number two, you have a right to left shunt with cyanosis. Number three, you have right ventricular hypertrophy. And number four, you have some form of right ventricular outflow tract obstruction. Let's look at some more over here. Firstly, we're going to look at the patent ductus arteriosus over here. And as we see there, we have a lesion that is connecting the aorta to the pulmonary artery, and we get a massive left to right shunt. Okay. Over here, on this side, we have total anomalous pulmonary venous drainage. And as you can see, basically what that means is that deoxygenated blood is draining into the left atrium. So deoxygenated blood is going into the left atrium. And then on this side, we have transposition of the aorta and the pulmonary artery. And that means that systemic blood is deoxygenated and blood going to the lungs is oxygenated. Now, the only way that one can survive in this case is because one has to have a PDA. So this is a circulation that we would describe as duct dependent. Because if you imagine that we had a heart, okay, whereby there is an issue where no blood can get out of this heart. Now, what are those scenarios? Tricuspid atresia, number one. So remember that there is a right atrium, then there is no tricuspid valve, and because there's no tricuspid valve, no blood has been pushing into the right ventricle, so it's almost non-existent. Now, in that situation, there is often a large ASD or VSD, so blood is immediately shunted from the right to the left, but this blood is deoxygenated. If that blood goes into the systemic circulation, and there is no other source of oxygenation, the child will die because 100% deoxygenated blood would be going systemically. So what is the child keep is the ductus arteriosus. Because in this situation, remember, we've got a very high pressure in the pulmonary circulation and we've got a low pressure in the systemic circulation, okay? So what happens there, okay, so then the last lesion over here is the Truncus arteriosus. So essentially what has happened there is that the aorta and the pulmonary artery have failed to separate, okay? They've transposed, so they've transposed. So that means that from the right ventricle, you have the aorta, and that is doing systemic blood, but that is totally deoxygenated blood going systemically. And in this scenario, you have the left ventricle ejecting into the pulmonary arteries, and this is deoxygenated blood at a very high pressure. This lesion, without a PDA or a VSD or something like that, is not compatible with life. So there are a few lesions, that are what we call duct-dependent circulation. So what is that? Well, duct-dependent circulation is, as it says, the child is dependent on a ductus arteriosus remaining patent in order for the child to live. Now, why is that? Well, in certain lesions, you have no systemic blood flow or no pulmonary blood flow, or you have or you have transposition, as I said, or a truncus where you've got a massive amount of deoxygenated blood going systemically. Now, in those scenarios, you need to get mixing of blood because we somehow need to get blood to the lungs. So let's work through the example of a tricuspid atresia. So in a tricuspid atresia, you obviously, as the name says, you have no tricuspid valve. Now remember, blood then goes into the right atrium. It goes into the, meant to go into the right ventricle, but that essentially doesn't exist because if there's no blood going into it, then it doesn't develop. So blood immediately, because there's going to be a high pressure in the atrium now, is going to shunt into the left atrium. That blood is then going to go down into the left ventricle and then into the aorta. But now, I haven't mentioned the lungs. So there is no pulmonary blood flow in this scenario. So that child in utero is fine, but once it's born, it will become cyanotic within hours of the duct closing, okay? So that is what we often notice in these severe congenital cardiac lesions, is that they start to go blue within the first 12 hours of life. So we then put these kids on Prostin, okay, to keep the ductus arteriosus open, and that is what we call a duct-dependent circulation. So if you look back here again, this with transposition has to have either a VSD or it has to have a patent ductus arteriosus. You need to get mixing of blood so that some blood can get oxygenated and some oxygenated blood can go into the ventricle. So these are the most serious of the lesions, okay? Duct dependents are tricky They are neonates, so they are small babies coming to Cath lab. The access is challenging, venous access, the Cath lab access for their sheaths and catheters. The ductus is very finicky, and if you get any stress response and things like that, it can close, it can spasm, so you often get reversal of the shunt again, or you get the drop in systemic blood flow, which is an issue. So these are quite high risk lesions, but they're the most fun to do, okay? So when we talk about lesion complexity, we talk about simple, moderate, and complex, okay? Now, obviously, as the colors show, green, yellow, and red in terms of their complexity, their difficulty, and their expected or risk of morbidity and mortality. So simple complexity is an isolated congenital mitral valve disease, isolated congenital aortic valve disease, an ASD, a VSD, a PDA, and a simple coarctation, where it's just a normal one narrowing after the takeoff of the third branch of the aortic arch. Then moderate complexity, as we said, is anomalous pulmonary venous drainage, either partial or complete. An AVSD, an atrioventricular canal defect, it's just a more complex left to right shunt. A B is the Ebstein's anomaly, that is of the tricuspid valve, where there is no tricuspid valve, and there is another duct-dependent circulation. Moderate to severe pulmonary stenosis or regurgitation. Sinus venosus defects, subaortic stenosis, or a straddling mitral or tricuspid valve. Essentially, that just means that they straddle the antrum and they don't close or oppose the leaflets properly. And then complex lesions, the highest risk, these should always be done in a facility with expertise in pediatric cardiacs and pediatric cardiac anesthesia, as well as pediatric ICU. These should be done at central hospitals in the state sector or at specialist cardiac hospitals in the private sector. Complex lesions are all cyanotic heart disease, including tetralogy of Fallot, a Fontan procedure. A Fontan procedure we will speak about a bit later. That is a procedure whereby all pulmonary blood flow is done via direct connection of the SVC and the IVC to the pulmonary artery, totally bypassing the right side of the heart, used for hypoplastic right heart disease. Mitral atresia, tricuspid atresia, pulmonary atresia, if they have a single ventricle physiology, so again, this is your hypoplastic left heart, that is terrible and much worse than a hypoplastic right heart. And then heterotaxy syndrome. So basically that's when things are swapped around where they shouldn't be. Okay? So when we look at the complications of congenital heart disease, we divide them into cardiac and non-cardiac, or cardiac and systemic. So the first one, and I've put in bold, is arrhythmias. And this is so important because it is the number one cause of sudden cardiac death in congenital cardiac disease. And this is for two reasons, okay? Number one, the lesion itself causes abnormal heart muscle, and so therefore there's abnormal conduction muscle. So they are prone to, in particular, tachyarrhythmias, and problematically sometimes malignant ventricular tachyarrhythmias. The second reason is because post-surgery, you've now cut open a heart. So if you imagine a tetralogy of Fallot, for example, what does that surgery involve? Well, you have to now separate this big right ventricle from this smallish left ventricle with a big graft, etc., across the defect. And so those multiple incisions, again, cause abnormal conduction tissue to develop. And so there is then a risk of arrhythmias. So for peds and adult cardiacs, whenever we do an open heart procedure where we cut into the myocardium, so anything that's not a cabbage, basically, in adults and kids, we put pacing wires in post-op that can then be kept in for as long as necessary if they develop an arrhythmia. But when you are presented with a scenario of a congenital cardiac disease for non-cardiac surgery, that is where you need to be particularly vigilant of arrhythmias. You need to do a pre-op 12-lead ECG. You need to make sure that these kids do not develop severe tachycardias from stress responses, pain, etc. The next issue is pulmonary hypertension, as we've said, from an increase in pulmonary blood flow. That can then lead, unfortunately, to an Eisenmenger's syndrome, which I've described, as where you get such right ventricular hypertrophy and such an increase in pulmonary vascular resistance that the shunt, that is normally a left to right, reverses, and the child develops cyanotic heart disease, where before he had acyanotic. They then get systemic hypertension. Again, this is in right to left shunts. Those increase in blood flow to the systemic circulation. It's got a fixed vasculature, and by increasing the amount, the volume, you increase the pressure. They then develop thrombosis because, again, they either have sluggish blood flow or they have a very high hemoglobin in the case of a cyanotic lesion, because they need to carry as much of that little bit of oxygen that is there as possible. So clotting is a risk. Poor ventricular function, either left, right, or both, therefore heart failure. And then ischemic heart disease, don't forget it. These children can develop what we call type 2 myocardial infarctions. A type 2 myocardial infarction is where the myocardial oxygen demand is higher than the myocardial oxygen supply. So it's not due to atherosclerosis and a decrease in coronary perfusion pressure and plaque rupture as it is in an adult. It is due to a drop in myocardial oxygen supply because they are cyanotic, so their PO2 is low, and they're tachycardic, and so their demand is high. So those are the complications from a cardiac point of view. What are the systemic complications? Well, when we look at the lungs, the first one is restrictive lung disease. So remember, this increase in pulmonary blood flow causes pulmonary hypertension, pulmonary vasoconstriction, and therefore causes restrictive lung disease, pulmonary hypertension, pulmonary hemorrhage, and plastic bronchitis. So this is an aseptic bronchitis that occurs due to this increase, a continual increase in pulmonary blood flow, and by definition, a bit of pulmonary edema and secretion retention. The liver, they get a congestive hepatopathy, they get cardiac cirrhosis, and there is something called Fontan-associated liver disease, which we'll speak about. Immunologically, they have protein-losing enteropathies, infective endocarditis, they're at higher risk of pneumonias, abscesses, and their cell-mediated immunity is lower. Hematologically, they get erythrocytosis, iron deficiency, hyperuricemia, thromboembolism, and anemia. Oncologically, they get exposed to a long period of low-dose ionizing radiation causing malignancy. They're at a higher risk of hepatocellular carcinoma, and we should be doing age-appropriate cancer screening for them. Psychosocially, these children are at very high risk for depression, anxiety, and PTSD due to having lived so long in the hospital and all the numerous painful procedures. And then remember that if they are cyanotic, or if they have got a decrease in systemic blood flow, they may have neurodevelopmental delay because the brain is not getting enough oxygen or enough blood. From the endocrine point of view, they develop thyroid calcium hemostasis issues. They get osteoporosis. They get obesity, metabolic syndrome, diabetes, dyslipidemia. They're at high risk for developing chronic kidney disease as well as cardiorenal syndrome. And then in the vascular system, obviously, cerebrovascular disease, pulmonary venous or arterial disease, aortopathy, so aortic disease, endothelial dysfunction, and hypertension. So as you can see, there's a lot of things that we need to go through in the preoperative visit with these kids before we can bring them to theatre. So what are the procedures that are done in the cath lab? Well, they can be divided into three. That is diagnostic, interventional, and electrophysiological. And I was the only consultant generally at Barra who would do the electrophysiology lists, because they're quite long, quite complicated procedures where the aim is to induce the abnormal arrhythmia that the child has. And so it goes against every fiber of your being as an anesthetist to try and induce a seizure in children. And so we have to give them a lot of DOBS. And what we really wished we had was isoprenaline, but it's not available anymore because that gives them a big tachycardia. But I used to love doing those cases. And we used to get a cardiologist who would come up from Durban, I think it was, or Cape Town, and she would do these procedures up in the Cath lab at Barra, and they were a lot of fun. So diagnostic procedures is defining the cardiac and vascular anatomy, most importantly, measuring the pressures in every single chamber of the heart, as well as in all of the great vessels. And this is done on oxygen and off oxygen. So we do pulmonary hypertension studies using, they say nitric oxide. We very rarely do that. What we generally do is they measure first on 21%. So we literally keep the child on room air. And then we increase the oxygen to 100%. And this is to see in certain lesions whether the child is amenable to surgery. That is because if you have a child that has got a left to right shunt, so they've had an increase in pulmonary blood flow, they have developed, as we've said, very rapidly over time, right ventricular hypertrophy and pulmonary hypertension. So now the problem comes in is that if the right ventricle ever fails, you have a natural pop-off valve. So if the pulmonary hypertension gets high and the right ventricle struggles, blood can flow from the right to the left. So you're still getting systemic blood flow. So what we do in the Cath lab, or what the excellent peds cardiologists do, VJ or Dave, they measure on room air what the pressure in the pulmonary circulation is. They then ask us to go up to 100% oxygen and they remeasure the pressure. And that pressure needs to drop. The child needs to be oxygen responsive. The PVR needs to be oxygen responsive. That means that the child will cope when we close that VSD or ASD and the right ventricle no longer has a off-ramp if it runs into trouble. Because now with the shunt closed and the normal series circulation in effect, that right ventricle needs to be able to pump against the pulmonary hypertension. So that's what we're testing when we do pulmonary hypertension studies, because we know that if the pulmonary vascular resistance decreases in response to oxygen, it means that the child can be put on oxygen therapy, nitric oxide, and sildenafil, post-op to decrease the PVR, and it will respond and the right ventricle will cope. We then do coronary angiography and endostonography, and we do biopsies. Then interventionally, we do a valvuloplasty. That is where we open a stenotic valve with a balloon. It's quite an interesting procedure because what they do is they thread a catheter through the orifice of the aperture of the valve opening, like that, if you imagine it like that, and they feed a catheter through, and they inflate a balloon for anywhere from 5 to 15 to 20 seconds. So if you imagine that balloon is occluding the entire mitral, tricuspid, pulmonary, or aortic valve. So for that period of 5 to 20 seconds, your cardiac output drops to exactly 0. Very scary, okay? You're going to get a massive tachy, drop in sats, and then maybe a Brady. Be brave, hold on, okay? It will pass. But obviously, we all there watching the monitor, and if the heart rate drops below 100, they will stop. It's better to do a few times of inflation rather than wait for too long on one. So that's valvuloplasty. Septal defect closure, atrial septostomy, angioplasty and placement of stents, percutaneous valve placements, closure of shunts, and hybrid procedures where you can do open combined with a cath lab procedure. And then electrophysiologically, we do conduction mapping of the system. We do radio frequency and cryoablation of abnormal sites of electrophysiological activity in the heart, and we can place pacemakers and ICDs. Remember, as I told you guys, these kids are at high risk for post-operative and later on in life malignant hypothermias, ventricular malignant arrhythmias, and so pacemakers are key for them in later life. What are the complications in the cath lab? Well, the complication rate in some studies is 7 to 11%. I must be very honest with you, that is incredibly high. I would say my complication rate at Barra is maybe 1 in 100, and my mortality rate was 1 in or 2 in 1,000 maybe. I think I had 2 children die in my 5 years of doing cath lab list. Cardiac arrest, they say here 1 to 2%. That's 1 in 100. Definitely not in my practice. Definitely not a complication rate of 10% or a cardiac arrest rate of 1% or 2%. I mean, that's 1 in 50. My God, no. And mortality rate of 0.3 to 0.5%. Again, that's what I could find in the literature. It's backed up, but it seems crazy. But maybe this is in less experienced hands or an overall picture. So what are the complications most commonly? Well, vascular, we have thrombosis formation of the vessels, aneurysm formation of the vessels, and vessel tears or perforations leading to strokes and embolisms. Malposition or embolism of the device. I once was in cath lab and we had a device that embolized past the PDA, down the aorta, all the way down to the branch of the left common iliac. And luckily, we could find it there. We had sent down, VJ sent down a guide wire, grasp it, and we put it back in the right position. But if it embolizes into the aorta and gets stuck, you get no pulmonary blood flow. If it embolizes into the heart, it can obstruct a chamber or it can obstruct the pulmonary vessels as well. So it is something that can be a bit of a disaster. Bleeding related, most commonly from the access site. Otherwise, retroperitoneally, there can be vessel ruptures and pericardial effusions. Arrhythmias. Catheter manipulation can cause valvular regurgitation, cardiac tamponade, hemodynamic instability. Wire can become fixated or stuck on the valve, and that's a pain, and then air embolus. And the risk of cardiac arrest is always there in these kids, and the risk of death. Remember, even if, guys, they look normal-ish, it's just a VSD, it's a small or just a PFO or just a PDA, and, room air stats are 94, and they look otherwise well, and they're not cynosed, guys, I beg of you, the biggest disasters happen in cath lab, peds cath lab, not because people are inexperienced, I think. It's because people get a bit over-experienced maybe, or they get a bit too comfortable, and they forget that even if every single one of those things on your screen is normal, heart rate, sats, blood pressure, oxygen saturation, oxygen content, pressures when they do the cath, etc., that is not a normal heart you're dealing with. Fundamentally, from a baseline, from an embryonal development point of view, the heart has developed abnormally. That's why it's a congenital cardiac. So guys, I beg of you, sincerely, it actually, gives me a bit of goosebumps when I think about this, because I think of I'll never forget the 2 deaths that I had in cath lab, and the one death in particular was a child who arrested just post-induction, who turned out on autopsy had an L kappa, which is something called a anomalous left coronary artery arising from the pulmonary artery. So basically, the left coronary comes from the PA, the pulmonary artery. So the left ventricle is getting ischemic blood from day one of life. And it's once those lesions, unfortunately, L kappas are almost 100% fatal. But guys, I was very good at what I did, maybe a bit cocky. I did this list all the time, and that child still died on the table, and it'll always stay with you. So please, I beg of you, these are not normal hearts, no matter what you think, and they will always behave abnormally, and they will always be at high risk for morbidity and mortality and complications. So we are then going to look at the catheterization risk score for pediatrics. This is something that we do in our preoperative assessment, and we can score the child based on their risk. So the first thing we look at is age. If they're over 1 year, it's okay. If they are less than, if they're 30 days to 1 year, this slide is incorrect. That should be a 1. And if they're less than 30 days, they're a 2. Weight, again, more than 5, 2.5 to 5, less than 2.5. Inotropic support, yes, no, unstable or stable. Systemic illness or organ failure, yes, no. And if it is yes, is it uncontrolled or controlled? Their category, 1, 2, or 3, that is their shock status, cardiovascular hemodynamic status category. Their diagnosis before Cath, as I said, is it simple, moderate, or complex? The procedure 1 is diagnostic. Procedure 2 is a small intervention, such as an ASD or a PDA closure. And category 3 is a complex procedure, such as the placement of a VSD, the placement of a VSD closure device, the placement of a doing a Fontan or a Blalock-Taussig shunt or something like that. And then again, the procedure type is an extra. So that is diagnostic, interventional, or hybrid. So who should I anesthetize then? Well, this is what they call the CRISP score. Okay, so this is the cardiac risk in Cath lab. So 0 to 1, the sedation, normal sedation team. So a very simple diagnostic cath in an otherwise well child with a moderate lesion, a simple lesion, sedation team. If there are 2 to 4, you should have an anesthesiologist with special experience in congenital heart disease. So that's maybe for closure, so for PDA closures or VSD closures, or for a diagnostic cath maybe on a tetralogy, but that's getting a bit dodgy. And more than 5, it must be a pediatric cardiac anesthesiologist. Now, I know in South Africa, we obviously have issues with skilled staff. So it can't always be a pediatric cardiac anesthetist, but it needs to be at least an anesthetist with special experience in congenital heart disease. And so what are the hazards of the cath lab? Well, it's to both us and the patient. It is the risk of ionizing radiation, okay? Very high risk. Remember, cath lab, with that rotating arm that gives them 3D images, it can be very high in ionizing radiation. And if it's a long cath lab procedure, they scan for a long time. They expose for a long time. Electricity or impact with stationary equipment. Blood products and microorganism risk. Pharmaceutical agents is just for the patient. There's the hazards of chemical solvents, acids, cleaners, etc. That's the staff, maybe the patient. Ergonomic injury for the staff, because it's very awkward in cath lab. You work in tight spaces, you climb on the floor, you get under things, you could slip, and then falls from the table or the gurney or the floor is the patient risk. So it's a lot of things you need to keep in mind. It is also remote site anesthesia as well. So when we do our preoperative assessment, we're going to do a history, we're going to do an examination, we're going to do an echo, always going to review the echo, other investigations, medication, and previous anesthetic charts. Critically important, guys, looking at a previous anesthetic chart is so key because it can tell you what airway device did they use that worked, because that's the first thing you want to put the same one in. You don't want to mess around or sickle or struggle with a congenital cardiac airway. You're going to see what drugs they give, what analgesia they give, what the SATs did, what FiO2 they needed to give. So guys, if somebody's worked the hard road, so if somebody like me who does this all the time and can do these often in his sleep, has done this before, have a look. Don't be too, you can never be too humble. Look at what I've done and copy that for a lot of it, or look what your colleagues have done, and it's very, very helpful, guys. So guys, when I do my pre-med visits in these kids, I have very specific and very important yes/no questions that I ask, okay? So in any congenital cardiac, these are the questions that I want to know. Number one, is there cyanosis? Number two, is there a shunt? And if there is it left to right or right to left? And where exactly is that shunt? Number three, is there obstruction to blood flow? So do I have a coarctation or an atresia or a hypoplastic heart, something like that? Number four, is there pulmonary hypertension? And if so, how severe is it? Mild, moderate, or severe? And is there accompanying right ventricular hypertrophy, dilatation, or right ventricular hypertension? Then, number five, is there an arrhythmia? If there is, what is it being treated with? Does the child have any devices inserted, such as a pacemaker or an ICD? And if the child has had an arrhythmia before, is there any documentation or history on what the cause or suspected cause of that arrhythmia was? Next, is the child in cardiac failure, yes or no? And if they are, how severe is the cardiac failure? Is it left ventricular or right ventricular? Or is it biventricular failure? Is it diastolic heart failure, what they call heart failure with preserved ejection fraction? Or in most of these kids, it is most commonly a dilated cardiomyopathy causing systolic heart failure or reduced ejection fraction. Have they had a previous cath or an anesthetic for anything else? Yes or no? If they have, what were the specific complications? How did they manage them? How did they do, etc.? What airway size devices, what fluids, what analgesics, what induction agents? And then lastly, is it an intervention or just a diagnostic? And those questions, if you can answer all of them, I promise you guys, with a bit of experience and a bit of like somebody like me or with experience teaching you, you can become a master in cath lab. So let's run over these again quickly. Is there cyanosis? Is there a shunt? Is there obstruction to blood flow? Is there pulmonary hypertension? Is there an arrhythmia or a history of an arrhythmia? Is there cardiac failure? Have they had a previous cath or anesthetic and get the notes or the chart from that? And then, is there an intervention planned, yes or no? So there are then a few more questions that I ask guys. And excuse me, I want to change this one. The question that I ask, importantly, is number one, am I the correct anesthetist? And guys, this is not a place for a lack of humility. This is not a place for ego. This is a place where there are children who are critically ill with complex lesions, who require somebody who is on their toes, who's experienced, who knows what to do, and most importantly, has done dozens, hundreds, and ideally in my case, perhaps thousands of these. So, 4 or 5 a week for every week for years, So, and the thing is that you need to make sure that, let's say you've done these lists a lot, but you've been doing, a lot of ASDs, VSDs, maybe the odd tetralogy, and then they come and they're like, listen, we've got a 3-day-old with transposition of the great vessels who's duct dependent and Prostin and on Dobutrex at 10 mics per kg per minute and who is ventilated on 90% oxygen, and they need to come for a cath. Well, that's a whole different kettle of fish, and that's when you call a friend, okay? My next question, where is blood flowing? Okay, so you always draw a picture, guys. So what I literally do is I draw a very old-fashioned square box. I'm actually going to literally draw it for you guys as we speak, okay? So this is what I do, okay, here. And I put all of the necessary things that we need. Okay, so from here, we've got a PA, and then here we've got a PV, and then coming out here we've got an aorta. So guys, I've used this many times, so don't laugh at me, okay? So this is what I've used to teach this many times. All right, so I'm going to put it here and just turn the camera down so you can see it, so that I can also see what I'm doing. So let me just annotate one more thing. I'm so sorry. So here we've got an SVC, and we've got an IVC, we've got a right atrium, we've got a tricuspid valve, right ventricle, we've got a left atrium, we've got a mitral valve, and we've got a left ventricle, and here we've got an aortic valve, and here we've got a pulmonary valve. Okay, so let's have a look at this again quickly. So as you can see, guys, we have my very rudimentary heart, okay? And so as you look there, if you look at on the the right-hand side, my right hand, okay, of the image, the left-hand side as I look at it on the screen, you have the superior vena cava, the SVC, and the IVC draining into the right atrium. What is the first lesion I've shown you there? I've shown you between the right atrium, RA, and the LA, the left atrium on the other side. I've shown you an ASD, okay? So here we have an ASD, okay? Here we've got a VSD, and here we've got a PDA, okay? So guys, if you look here, okay, these are the most common right to left shunt lesions that I've just sketched here, and this is what I do for every list. So if you look again, we've got RA, blood is coming from SVC and IVC. So if there is a gap between the RA and the LA, that's an ASD, and blood will shunt from the left atrium into the right atrium, left to right shunt. You've then got the tricuspid valve, then the right ventricle. I've then shown a VSD between the right ventricle and the left ventricle. That again is a left to right shunt, a much greater shunt fraction, a much more serious lesion. We then exit the right ventricle through the pulmonary valve. We can get congenital pulmonary valve stenosis. This is where at the pulmonary valve we get a tetralogy of Fallot, and I will show that for you now. Then we have the pulmonary arteries. That is where we can get issues with pulmonary venous drainage and supply. And then we've got a connection, as you see there, between the pulmonary artery and the pulmonary artery here and the aorta over here. That again is a left to right shunt called a PDA. Then if you look back at the top right of the image, over here, you have pulmonary veins draining into the left atrium. That is the site of total anomalous pulmonary venous drainage. We then have the mitral valve. That can be a site of congenital mitral stenosis or mitral atresia, causing a hypoplastic left heart where you no longer have a left ventricle. And we then finally have the aortic valve with blood leaving the aorta. So I'm just going to sketch, if you won't mind, guys. I'm sorry, give me 2 seconds. This just came to me spontaneously. I'm now going to show you what a tetralogy of Fallot looks like, okay? So in a tetralogy of Fallot, okay, guys, and if you will just bear with me for one more second, I am going to get a red Cokie to show you the direction of blood. Sorry guys, I'm back. So if we look here, Okay, so what I'm just sketching here, guys, is where blood goes. So what happens is okay. So if you look at my wonderful sketching, I'm certainly not going to win any art prizes, but you know, Picasso drew some weird things, and it worked for him. So let's just look here again, guys. So what am I showing here? Here I'm showing a tetralogy of Fallot. Okay. So what is the tetralogy of Fallot? As I've shown here, it is where you have in that right ventricle. What I've scratched in there in the black is to show you how thick the ventricular wall is. So look here, we have our right ventricular hypertrophy. Here we have our VSD, okay? And then down here we have our third aspect where I've colored in the pulmonary vein, our artery, and the pulmonic valve is stenosed. We have the right ventricular outflow tract obstruction. And because of that, we have deoxygenated blood from the right atrium going to the right ventricle. It does not go to the lungs because it cannot get there because of the obstruction. And so therefore it shoots across to the left ventricle where deoxygenated blood plus oxygenated blood equals deoxygenated, decreased oxygenation. Okay, so that's the sketches that I do for my regs and my juniors, but I also do for myself. Okay, next, how can I keep it that way? So what do I need to do to make sure that where the child is now is where they stay? So stay with a left to right, stay with a right to left. What am I doing with PVR versus SVR? So what does that now mean, guys? So what am I doing with PVR versus SVR means that I am asking myself, what currently is the pulmonary blood flow to systemic blood flow ratio? So remember I said that it's meant to be 1-to-1. If I have a left to right shunt, it means that my pulmonary blood flow has increased, and therefore, by definition, my pulmonary vascular resistance is increased. What it also tells me, and this is critical to keep in mind, guys, is that your SVR is decreased. Why? Because you've got decreased systemic blood flow. So what does this tell you? Is that currently the child is sitting with a higher pulmonary blood flow and pulmonary vascular resistance, and a lower systemic vascular resistance and a lower systemic blood flow. Now, what does anesthesia do, guys? It changes those things drastically, okay? Because what does it do? You induce anesthesia, you give propofol, you give Sevo, no matter what you do. Even you give a bit of etomidate, you're going to get a drop in SVR. So we lower the already low SVR, okay? Now we give oxygen to the patient. So they get hypoxic pulmonary, pulmonary vasodilation because of the increase in oxygen. And so their PVR decreases. So now the gradient between the two chambers in the heart is increasing because the left ventricle is ejecting against a much lower afterload, so the stroke volume increases. The lungs are accepting more blood because the PVR has decreased, and what you're going to do is you're going to worsen the shunt fraction, okay? So I'm going to come to my rules for these, but for these, for left to right shunts, we follow, and I have to give her credit, Dr. Ellen Kemp, probably the best cardiac anesthetist that this country has ever produced, and certainly the, in my opinion, best anesthetist that Wits has ever produced. And her rule was the 40-44 rule. So this is in order to balance PVR and SVR. So to keep the systemic vascular resistance and the pulmonary vascular resistance roughly the same. Because if you increase the PVR, you will reverse the shunt potentially. You might force blood from the right ventricle to go into the left ventricle. Or, as I've just explained, you may cause the shunt fraction to worsen by dropping the PVR too much. So what is the 40-44 rule? This is the rule. Again, shout out to Dr. Ellen Kemp. This is where for a left to right shunt, acyanotic congenital heart, such as a ASD, VSD, or PDA, when you induce anesthesia, you never go above 4% sevoflurane, and you never go above 4% sevo for the whole procedure. You never give more than 40% oxygen in order to not drop the PVR too much. The sevo at 4% is so that you don't drop the SVR too much. And 40 is your end tidal CO2, so that helps with vasoconstriction as well. So I'm going to run through it again. For congenital left to right acyanotic shunts, the rule in anesthesia is 40-44. Sevoflurane, no more than 4%. FiO2, no more than 40%. And maintain the end tidal CO2 around 40 as tightly as possible. And that is the 40-44 rule. And I must be honest with you guys, in my entire pediatric cardiac anesthesia career as both a registrar and a consultant, it has not failed me once. Then you need to ask, in this patient, what are the most likely complications? And that you do based on that table that I showed you guys. And you look at which of these complications does my patient have, or could they have? And then what is my plan for this patient if something goes wrong? And what do I mean by that? If something goes wrong, it's generally two things that happen, okay? If they are at a cyanotic congenital heart, something happens either due to the anesthesia or due to the cath, and the shunt fraction gets worse, and so they shunt more blood from the right ventricle or the right side to the left side, and they become more hypoxic. How do you fix that? Well, firstly, you need to give oxygen to try and increase as much oxygenation as possible. But secondly, and the critical thing here, guys, is in this instance, what is happening is your PVR is higher than your SVR. That is what's causing a shunt reversal. And we're going to go through this again quickly at the end. But that means you need to increase the SVR and you need to decrease the PVR. Now, if you've got a left to right shunt, you need to consider exactly what I've told you before. Am I going to worsen the shunt by dropping the PVR too much? Or am I going to worsen the shunt by increasing the PVR too much and dropping the SVR too much? So again, as I've said, those are the most common complications. You worsen the shunt, okay? So you've either increased the PVR too much or you've increased the SVR too much most of the time. In your shunts that are obstructive, the most common complication or the most common issue in the cath lab is that they are duct dependent. And so therefore you do something and the duct doesn't like it and closes, and you start to get a drop in systemic oxygenation. So guys, I'm just going to run through again my questions that I ask is, am I the correct anesthetist? As in, do I have the correct knowledge, experience, and self-confidence to do this case? Where is blood flowing? Draw the heart as I did, okay? So learn how, guys, to draw this type of picture, okay? And do it over and over again and sketch the different lesions, all right? Promise it'll help so much. Ask yourself, how can I keep the blood flowing that way? Remember, your job is to change nothing that's happening here, okay? Keep the child where they live before you met them. What am I doing with the PVR versus SVR ratio? In this patient specifically, what are the most likely complications? And I've told you those. It's that you're going to either worsen the shunt fraction, or you're going to get some sort of issue where a duct-dependent circulation starts to close, or you're going to get an arrhythmia that's going to cause issues. Those are the three most common complications. And ask yourself which of these complications is most likely in your patient. And then, as I've said, what is my plan for this patient if something goes wrong? So guys, let's get back to how I do these. So these are my rules, okay? And what do my rules mean? It means This is kind of what I tell everybody starting out in Cath lab. And I say to them, if you stick with this, I promise you, you'll be okay. So number one, ketamine is your friend. Remember, ketamine does not drop the systemic vascular resistance, and it does not cause a bradycardia. So it keeps your heart beating nice and fast, and it keeps your SVR high. It's a great drug. If you don't have intravenous access, you don't go gung-ho and do 8% sevoflurane gas inductions, especially in cyanotic hearts. So IMI ketamine, 2 milligrams per kilogram, is very safe as a sedative. And pre-op IV access is ideal and should be mandatory in my opinion. Now, for these cases, my general rule, okay, is that excuse me, I keep moving the wrong one, is that I use a LMA for all diagnostic procedures in children who are more than 10 kilos or who don't have an issue with their airways, okay? For everybody else, I use an ET tube, so for all interventional procedures. And if the child has got a difficult airway, if it's going to be a very long procedure or less than 10 kilos, I put it in an ET tube. Guys, the last thing on earth you want is to sickle and struggle and faff around with an LMA and you get a laryngospasm and hypoxia. And if I'm honest, that is exactly how my child who had an unfortunate DOT on table died. Was the iGel LMA put in by the registrar didn't sit properly, the child got light and spasmed, and I managed to break the spasm in exactly 5 seconds. However, the SATs dropped to 82%. The child brady'd, arrested, and we could never get him back. And that was the child with an L Kappa. So don't faff around. If you're nervous or whatever, just paralyze them and stick in an ET tube. Obviously, I've done lots of these. So as I said, LMA for diagnostics, ET tubes for interventions, or if you're worried. 8% sevoflurane is a definite no. Propofol, I give it 0.5 to 1 milligram per kilogram maximum. And I say to my registrars, my trainees, and my colleagues who are less experienced, propofol is a no then. Just use etomidate and ketamine. Don't risk dropping the SVR with propofol. I always like to leave them on spontaneous or pressure support ventilation. Unless I have to, I prefer to not fully paralyze and control them, because remember that positive pressure ventilation can change the PVR to SVR ratio. Specifically, it increases pulmonary pressures and therefore increases pulmonary vascular resistance, which can worsen your shunt. I give all of them a fluid bolus of a minimum 10 to 20 mils per kilogram. It makes a huge difference. Be wary of underlying cardiomyopathies. Children with a cardiomyopathy, a dilated cardiomyopathy, are sick, and I always put them with Wobutrex on the line, ready to go, and ephedrine and adrenaline boluses drawn up. Complex lesions always require mandatory pre-op IV access. And guys, I cannot say this enough, a drop in heart rate means take action now, okay? These are not normal kids. I've said it once, I'll say it again. They do not have normal hearts, okay, guys? Please, I beg of you. A bradycardia means stop, aware, push the button. This is a problem. Give adrenaline, give oxygen. Do not let these kids brady, because if they arrest, a lot of congenital cardiac hearts are unresuscitatable. Okay. So I'm going to say my rules again, guys. Number one, ketamine is your friend. It increases SVR and it increases heart rate. It doesn't cause apnea. IMI ketamine is perfectly safe and useful as a pre-op, a premed to get IV access. Pre-op IV access is ideal, if not mandatory. If they are less than 1 year of age or less than 10 kilos, I always intubate. And if they're doing any interventional procedure, I put in an ET tube. In all others, I will put in an LMA unless I'm worried about the airway. But that is in my hands. If you are worried, please put in an ET tube. 8% sevoflurane is a big no. That vaporizer should never go above 4%. If you're going to give propofol, which I discourage, if you are not very experienced, no more than 0.5 milligrams per kilogram, but rather avoid it. Put them on spontaneous or pressure support ventilation so that you don't increase the afterload in the right ventricle and worsen the shunt. Give them all a fluid bolus of a minimum of 20 mils per kilo. Congenitals are always dehydrated. Congenital cardiacs are always dehydrated. Be wary of cardiomyopathies. They can be fatal. Complex lesions must have pre-op IV access, and a drop in heart rate means take action now. So, the next thing we do that is critical is the team meeting, the huddle, the timeout. What do? We review the list and specific patient concerns. We confirm if cross-match or blood is available. Remember, guys, that in a small child, blood loss of 10, 20, 30 mils is significant. So all of these children, if they have a low HB to start, they should have blood in theatre, or they should have blood in at blood bank. They don't tolerate anemia. Any special equipment or monitoring that's needed out of the ordinary. What are the imaging requirements? So where do they need to image? For how long? What part of the heart? Do you need to give antibiotics? What is your plan to keep them warm? Because that is really a challenge. Cath lab is cold because of all of the machinery. Identify who the cardiologist is, who their assistant is, who the aniththetist is, and who their assistant is, and what everybody's role will be in an emergency, and then any special issues or concerns related to this patient specifically. The actual anesthetic, guys, number one, preparation is key, okay? We need a defibrillator with paddles and pads available, okay? So you need a pediatric appropriate defibrillator. You need to know the dosage of joules needed, okay? Remember, it's 4 joules per kilogram, okay? So you need pads if they have one arrhythmia and you need to shock them. But after that, what we would do is we would slap the paddles to shock them once, and then we slap pads on, okay? And then that's ready to go if we need to shock them again. In this case, I would draw up or have available a lot of emergency drugs. I will always have rocuronium drawn up. I will always have phenylephrine drawn up, and I will always have atropine drawn up. I will then have adrenaline, noradrenaline, dobutamine, esmolol, adenosine, and sodium bicarbonate available. In some instances, if it's a complex case and I'm worried, I will have adrenaline drawn up already. For tetralogy of Fallot's, I will have esmolol drawn up, and I'll explain why. But again, depending on how experienced you are or how scared you are, then you will draw up emergency drugs as you need, okay? So what is the next rule for induction? Go low, go slow. 2 SATS probes must be on the patient, okay? Pre-ductal and post-ductal. IV line pre-induction is ideal. Give small incremental doses of volatile and induction agents. Remember, guys, that in these hearts, 100% oxygen is not always ideal. 60% should be given at a maximum. And remember, in the left to right shunts, 40-44. Remember to maintain as much as possible the balance between PVR and SVR. The next thing that you need to be aware of is, how do I do a left to right shunt? Well, my goal, as I said, is to balance PVR and SVR. So what does that mean? I do a slow gas induction, sevoflurane 4%. I establish an IV line and I give ketamine 1 milligram per kilogram, propofol 1 milligram per kilogram, and fentanyl 1 mic per kilogram. I put in an LMA or ET tube as appropriate. I then follow the 40-44 rule, FiO2 of 40, end-tidal CO2 of 40, and an end-tidal SIVO of 40. I use controlled, pressure controlled or support ventilation. I give a fluid bolus of 20 mils per kilo. I give them Decadron only for analgesia, local to the wound site, and Perfalgan for analgesia, and Decadron for post-operative nausea and vomiting. How do I do a tetralogy? Excuse me, I keep moving the wrong one. I'll get used to this, guys. I'm still new. I'm a much better anesthetist than I am technical person. So what do I do? How do I do a tetralogy of Fallot? We do an IV line pre-induction, okay, always. I give them IMI ketamine, 2 to 4 milligrams to facilitate the line, PRN, putting in the IV if needed. I then give ketamine 1 to 2 milligrams per kilogram IV, and I only add propofol 1 milligram per kilogram if the child is quite well and their SATs are above 70%. I only use SIVO maximum 2% for maintenance. I have what's called a TET spell tray ready. Very good analgesia is needed, and I use controlled ventilation in this instance, okay? So, how do I, excuse me again, guys, I'm so sorry. How do I maintain the anesthetic? Okay. Number one, immobility is key. Okay. They mustn't move. So paralyze them, guys, or make sure that they are deep enough, but not too deep. You need to actively warm them. Warm fluids, bear huggers, they get cold. These procedures are not generally painful. Okay. So normally local, 1 mic per kilo of fentanyl, and Perfalgan, 20 milligrams per kilogram is more than enough. Change your FiO2 up and down as needed. And remember, I told you that they're going to ask you to do measurements on 21%, and then they're going to ask you to do measurements on 100%. Monitor both SATS probes closely and try as much as possible to keep the blood pressure as close to pre-induction values as possible. On emergence, what do? I do a deep extubation because coughing can be an issue in these kids. You don't want to raise intrathoracic pressure and PVR. Number two, if they cough, there is an increased likelihood that if the device that has been used to close the ASD, the VSD, or the PDA, then the device can embolize with that coughing force, okay? And I have had one incidence of that where I had to take a child back to theatre to fetch the device because it had coughed in the ward or in recovery, and then when they did the post-op echo, they had found that it had embolized. But beware of hypoxia or hypercarbia, okay? So you need to make sure that they are maintaining their SATs on spontaneous ventilation before you remove the LMA or the ET tube. Remember, minimal analgesia is required, so don't ever give them morphine, please. Puncture site monitoring is essential. You need to monitor for bleeding or a hematoma, and therefore these kids need to be kept for a minimum of 30 minutes with a compression dressing in recovery. And remember that complex kids or critically ill children will definitely go to high care or ICU post-operatively. Oh, excuse me, I think I missed a slide. Okay, so as I've said to you before, guys, what are the problems that one can encounter in cath lab and in these cases? Initially, most commonly is shunt reversal, as I've said. And this is usually most commonly due to a drop in SVR and an increase in PVR. Okay, so what happens here is that, as I've said, they become hypotensive, so their SVR drops, their blood pressure drops from the anesthetic, and or the PVR increases because they have a bronchospasm, a laryngospasm, or something like that. Okay, so what is the treatment? Number one, reduce PVR by increasing oxygen and increasing the respiratory rate to blow off CO2. You need to increase the SVR, and that is done by giving the pure alpha-1 agonist, phenylephrine. Now, you need to keep in mind, and it can be very disconcerting, guys, these are young kids they have got immature receptor reflexes and receptors. So you need to give a big dose, 5 to 10 mics per kilo as a bolus. Reduce your volatile to 1%. Give a fluid bolus of 20 to 30 mils per kilogram, and then alkalinize the patient if you really are struggling. What does that mean? Give 1 mil per kilogram bolus push of bicarbonate, sodium bicarbonate. When that reaches the lungs, the extreme increase in pH, the alkalinization, causes the pulmonary vessels to automatically dilate and drop the PVR. So what happens, guys, when your shunt reverses? I'll say it as a summary. Usually it's due to low SVR. It can be due to high PVR. You need to reduce the PVR by increasing the O2. You need to increase the SVR by giving 5 to 10 microgram per kilogram boluses of phenylephrine. You need to reduce the volatile to 1%, give a 20 to 30 ml per kilogram fluid bolus, and alkalinize the patient with 1 ml per kilo of sodium bicarb. Now, guys, the next question is, what is a TET spell? So it's what we call a tetralogy spell. So remember I showed you guys, if we look here quickly again at my beautiful drawing, I'm so proud of it actually. So if you look here, guys, the pulmonary vein is over here, all right? And there where I've done that little drawing over there, that is your, if you look there closely, your infundibulum, that is hypertrophied, and that is where you get your RVOT, your right ventricular outflow tract obstruction. So what do you need to do? Well, what causes it? It's most commonly caused by pain, anxiety, acidosis, and hypoxia. It causes a profound hypoxia with a decrease in pulmonary blood flow because you get even less blood flow to the lungs because that infundibulum is tight. Your goal is to force blood through these lungs and relieve the spasm. So you have to massively increase the SVR. Remember, you can't decrease the PVR here because the problem is not the PVR. The problem, remember, if I show you this drawing again quickly, guys, the problem is post the ventricle. The problem is here, okay? But after that, if you look over here, guys, over here, there's no problem in the pulmonary vessels, okay, in the pulmonary artery. So you need to increase the SVR. So you give an immediate fluid bolus, 20 mils per kilo. I give analgesia just to make sure that it's not pain, and I do that by giving 2 mics per kilo of ketamine. I reduce the volatile or switch it off if necessary. Phenylephrine, 5 mics per kilo every minute as needed. Ismalol, 0.5 milligrams per kilo as needed boluses. And remember why? Because the infundibulum has got beta receptors, and so by giving a beta blocker, you help the infundibulum to relax. Squatting or femoral artery compression increases the SVR significantly, and that forces blood back into the lungs. If we are really struggling and we really have a problem, then we can stent that infundibulum. We can put them on inotropes. And then lastly, there have been incidences where the SATs are persistently low that we've put in a temporary stent across the infundibulum and taken them straight to cardiac theatre for an open heart procedure. So guys, again, I'll run through it quickly. What is a TET spell? It is infundibular spasm causing right ventricular outflow tract almost total obstruction, most commonly triggered by pain, acidosis, anxiety, hypothermia, and hypoxia. It causes a profound decrease in pulmonary blood flow and profound hypoxia. We need to force blood into the lungs by increasing SVR. So we give a fluid bolus of 20 mils per kilo. I give ketamine to make sure that they're not light and that they don't have pain, 2 milligrams per kilogram. I switch the volatile off or reduce it to 1%. Phenylephrine, 5 to 10 micrograms per kilogram per dose every 1 minute. Esmolol, 0.5 milligrams per kilogram per dose every 5 minutes, and that relieves the infundibulum spasm. You can squat them or do femoral compression. You can give bicarb, 1 to 2 milliequivalents per kilogram, put them on inotropes, stent, or rush them to cardiac theatre. Oh, let's go one back. Okay. What about sedation? Okay. In a lot of places, they do talk about doing sedation. In my experience, and for me, only for diagnostic caths in simple cases. So what do I use? I give some ketamine, and you can give ketamine 5 to 10 milligrams per kilogram as needed. I stick to the lower dose of ketamine as possible because I don't want to get hypersalivation. Propofol, low dose, TIVA. So that means at a target of 1 to 2 marks per mil. Dexmedetomidine, very, very slow at 1 to 2 marks per kilo, or as an infusion. However, beware of the bradycardia. So the problems are secretions, movement, ventilation can be an issue. We don't want them to retain CO2 and become hypoxic. And then, guys, my biggest area of concern with this is that the airway is not secure. And if we have an emergency, so let's say the shunt reverses, let's say you're brave and you're doing sedation for an intervention, and the device embolizes, or they develop an arrhythmia, and you're now struggling with an airway as much as that. I'm sorry, but I don't have enough time, energy, and cortisol stores in my entire body to welcome that type of stress in my life, guys. So sedation for the braver, but for me, I'll only do sedation for a very simple ASD, VSD, or PDA diagnostic only. Okay? So guys, we need to go back to our scenarios. Okay? So we have a 14-day-old, okay, neonate with sudden onset heart failure and cyanosis for diagnostic cath and intervention. What is the most likely diagnosis? Well, it's got some sort of duct-dependent circulation, because what did I say to you? When does the duct close? The ductus arteriosus? Day 14. So this child has most likely got a tricuspid atresia, or he's got a transposition of the great vessels, or a truncus arteriosus, or a hypoplastic left or right heart. Okay? So what is my anesthetic plan? So this is a critically ill child with a complex lesion. High risk, should only be done by me, a peds cardiac anesthetist in a hospital that is a peds cardiac center. And my plan here would be a ET tube for sure, would be an IV line pre-induction. I would give only ketamine and a little bit of muscle relaxant, a tiny little bit of volatile. I then need to maintain the integrity of that PDA. So I need to make sure that the child doesn't become acidotic, hypercarbic, have pain, hypothermia, or hypoxia. Okay. Our next scenario, guys, is we've got a 2-year-old with a tetralogy of Fallot for diagnostic cath. What is my anesthetic plan? My anesthetic plan here for me would be a pre-op IV line, definitely. IMI ketamine as a premed if needed. I would then do a very, very slow induction with 1 milligram per kilogram of propofol, 1 milligram per kilogram of ketamine, and 1 microgram of fentanyl. I would put in an LMA in this child. For me, if you're worried, ET tube. I would then use pressure support or pressure control ventilation, okay? And I would maintain the 40-44 rule, meaning end-tidal CO2 of 40, FiO2 of 40, and a sevoflurane of no more than 4%. What is the most likely complications here, remember, is a TET spell. And I've got on my TET tray, I've got fluids, I've got phenol, I've got esmolol, I've got adrenaline, I've got bicarb, okay? And I'm prepared for a TET spell, and I plan for that specifically. Our third scenario is a 3-year-old child for a VSD, with a VSD for device closure. What is my plan? Well, as I said here, guys, for me, it's an intervention. So it's an ET tube. It's an intervention. So it's an IV line pre-induction, which can be facilitated again with IMI or oral ketamine if needed as a premed. I will then put in an ET tube and induce, as I said, 1 milligram per kilogram of propofol, 1 milligram per kilogram of ketamine, and 1 mic of fentanyl. I would then, again, remember this is a left to right shunt, so I would do the 40-44 rule. And again, what are the most common complications in this scenario? We've already been through it. Number 1, arrhythmia, arrhythmia, arrhythmia. We've got a hole in the heart, and we've got a device going in with lots of wires. Number 2 is shunt reversal, okay? And number 3 would be device embolism. 4 and 5 would be bleeding or hematoma formation from the sites. Then our last scenario, guys, is a 4-year-old with a hypoplastic left heart. What is important to know here? Well, what is important to know here is where is blood going, okay? Because if we go back to my trusty, I'm so proud of this, guys, you have no idea. My trusty picture here, okay? In a hypoplastic left heart, there is no left ventricle, okay? So what I need you to imagine is that the left ventricle doesn't exist, okay? So let's look at this again quickly, all right? So if the left ventricle doesn't exist, guys, how in the world is this child going to get blood systemically? Well, it has to have a PDA or a massive ASD, or what they call a common atrium. Okay, so what is important to know here is it a PDA or is it a massive AVSD that this child has? What is my plan? Again, it's a complex, so it's me, a specialized cardiac team, a peds cardiac team. We're going to do an ET tube, we're going to have an IV line, and it's the same recipe as I said. Ketamine if needed as a premed, 1 of propofol, 1 of fentanyl, 1 of ketamine, and then I'm going to use pressure control ventilation. And what am I worried about here, guys? Again, is the shunt closing and reversal of the shunt. So in this instance, we need to maintain systemic blood flow. So we don't want to increase the SVR too much. And we want to maintain pulmonary blood flow. So we want to lower the pulmonary vascular resistance by giving an increased FiO2. What about electrophysiological studies, guys? Well, what are they doing here? Their goal is to identify and buzz or ablate aberrant pathways. These are long procedures and the kids get cold. Your goal is to induce the arrhythmia, and for these, I actually use a low-dose TIVA or very low-dose volatile because you need to be able to induce a tachyarrhythmia. I induce the tachyarrhythmias with either ephedrine, adrenaline, or dobutamine boluses to get a tachy, and they sometimes stimulate the inside of the ventricular atrium to get the tachy, and avoid antiarrhythmogenic drugs. So don't give these guys beta blockers. Don't give a lot of analgesia. Don't make them too deep, okay? So guys, in summary, I really hope you have enjoyed this episode. I have had an absolute blast going through it again. I can't tell you guys, really. I mean, we're almost at 1 hour and 45 minutes, so you can surely see. So in summary, guys, thank you for staying with me for so long. I really hope you've enjoyed this. Number one most important thing, guys, is to understand common congenital heart disease lesions. Draw the picture. Where is blood flowing? Ask yourself that all the time. Ask yourself that when things are going well. And more importantly, ask yourself that when things are going wrong and pear-shaped, because then blood's going in the wrong direction. How do I keep it that way? How do I keep this child as they appear to me lying in the bed, smiling at the pre-med visit? Rather be safe than sorry, IV line pre-induction. Go low and go slow. No big boluses, no big doses of anything in these kids. Balance PVR and SVR and have a plan preoperatively for an intraoperative disaster. So guys, I have had an absolute ball doing this lecture with you. Thank you so much. I am so grateful. And please continue to watch, to like, subscribe, and share. Look down below in the bio. There's links to everything. And have a safe evening. Have a good week. And you will see me again on Friday. And I may be dropping some bonus content on Wednesday. So stay tuned. And this has been Dr. Tristan for Dr. Tristan's Anaesthesia Tutorials, Episode 2, Congenital Cardiac Disease, Help, I've been allocated to Pete's Cath Lab. Like, share and subscribe, guys, down below.